Good morning, good afternoon for us, good morning in USA, and I am very happy to meet you again and to talk again about an update on pancreatic islet transplantation in the setting of the European Congress of Transplantation. First, I want to introduce Thierry, Berney from Geneva for his update on islet pancreas transplantation.
Okay, perfect. So, hello everybody. So my name is Thierry Berney from the University of Geneva, and I will start this webinar by giving you some insight into long-term islet graft survival. So first of all, I have no conflict of interest to declare, and you are welcome to share the details of this presentation, but it's like drinking, you have to do it responsibly. So this is the outline of my presentation. So first I will define what is graft survival. I will give you the long-term survival data and then discuss briefly how long-term graft survival can be achieved before concluding this brief presentation. So defining graft survival, these are data from the collaborative Islet Transplant Registry, and you see that this is for islet transplant alone. If you look at insulin independence, we have 50% reported to the registry at 1 year, 30% at 5 years. If we look at C-peptide positivity, which is a reflection of the endogenous islet insulin production, it's a little bit better, 80% at 1 year, 50% at 5 years. If we compare that with the pancreas transplant registry, which is UNOS data from the US, you see that the results are, in terms of insulin independence, are better than for islet alone, slightly only. And they compare very well with C-peptide positivity, 75% at 1 year and 50% at 5 years. But here we have only data of, insulin, do they take insulin or not? Is C-peptide positive or not? But there are data that we are missing there. We don't know how stable is glycemia with this, and we don't know what is the HbA1c value. We don't know how well controlled their blood sugars are. So we should really define graft survival, and there is a lack of consensus about that. When we consider kidney transplantation or liver transplantation, we have very clear indicators such as return to dialysis, death or retransplant. These are clear signs of graft loss. For pancreas and islet transplantation, what is the definition of graft loss? Is it return to insulin? Is it the loss of C-peptide? If you have still C-peptide or no insulin or little insulin, is it failure? Is it still acceptable? So there is a need for a consensus definition that would be applicable to pancreas transplant, to islet transplant, but also to future regenerative medicine options. And this would also allow to compare all three modalities that I'm just talking about. So in this regard, a meeting took place a few years ago, and the results of which was published in Transplant International in 2018, with the aim to define outcomes for beta cell replacement therapy, outcomes of pancreas and islet transplantation. And defining outcomes is defining function, but also defining success. And briefly, this is what came out of this meeting. There was the clear consensus that success does not equate insulin independence. So beta cell functional success was classified with a 4-tier system, with optimal function, good function, marginal function, and failure, based on HbA1c, insulin requirements, C-peptide, but also the occurrence of severe hypoglycemic events. And based on these four sets of definitions, optimal or good function was classified as success, and marginal or failure was classified roughly as a failure. Now, in the IPITA Congress of 2019 that took place in Lyon, we found the need to refine these Eagles criteria. And there was a working group that presented data, compared data for different centers, compared pancreas and islet using the Eagles criteria, and just published in a preprint form last week is what is called the Eagles 2.0 criteria, in which I will not go in detail into that, but in which we decided to integrate continuous glucose monitoring system data into the definition of beta cell graft outcome, beta replacement therapy outcome. And we still have optimal and good function as a success, and marginal and failure as a failure. So you can go into this this paper to check this into details. I think this is not the time to discuss that in detail. So let's move to data, and let's move to a long-term graft survival. In the past, achieving a long-time insulin independence was extremely rare. And indeed, this patient transplanted in Geneva in 1993 was the first patient ever to achieve 10 years of insulin after an islet transplantation. And this patient unfortunately died 13 and a half years after transplantation, still off insulin, still with a perfect control, HbA1c below 6, good C-peptide, positive fasting and stimulated C-peptide, and she died of a stroke. And we asked permission to the family to do an autopsy and to publish the results of the autopsy. And you can see here, this is the liver. You can see that inside the liver, there are lots of islets that all stain positive for insulin. They are a very, very small size though. In the pancreas, because one question was, did the islet regenerate in the pancreas? This was not the case. There was one isolated beta cell there, but the islets were there, but essentially containing glucagon. So what kind of long-term graft survival data do we have now? We have data from the collaborative Islet Transplant Registry, which I briefly showed you before, but they are at 5 years. At 10 years, we only have data published from the University of Lille and from the GRAFT network, Geneva and France. These were published very recently, and these are the only actual 10-year graft survival data. At 5 years, we also have data from the University of Illinois and from the University of Alberta, published in 2005. The University of Alberta has very good data, long-term data, more than 20 years now, and but they have not been published. They have been incorporated into the CITR. We don't have an individual center from Alberta or from any other center published. So these are the results from Lille. You can see here at 10 years that the results are pretty good in Lille. They have 37% insulin dependence at 10 years, but it's only 5 patients. Again, these data are not actual, they are actuarial. And patient with graft survival is almost 80% at 10 years, which is extremely good. 28 patients are reported here. And when they looked at islet after kidney or islet transplant alone recipients, you see that there was no difference either in insulin dependence or C-peptide positivity. What about Gragil? Again, these are the only actual data at 10 years. And you see that here the data are not quite as good, we have 65% C-peptide positivity at 10 years, and there is no difference between islet after kidney or islet transplant alone. Still, in this Gragil paper, just out in the American Journal of Transplantation, you can see that up to 5 years, HbA1c is very good. It's slightly higher at 10 years, but still better than baseline. Same for fasting glycemia. Insulin requirements tend to go up a little at 10 years, but not to the same extent that before transplant. And the number of patients who are free of severe hypoglycemia with HbA1c below 7 is more than 80% for islet alone and 60% for islet after kidney. What about simultaneous islet kidney? Because this is something that is not very well known and not very well reported. These are the data from Geneva. I just recently presented that at the British Transplant Society Congress. And you see that we have, for the overall cohort, this is a follow-up of 2 to 24 years, 60% of graft survival at 5 years. And when we look at the two most recent era 3 is the Edmonton protocol, era 4 is with a thymoglobulin containing protocol. We have about 80% or more graft survival at 5 years and 43% insulin independence at 5 years. So let's also briefly look at the impact, because this is important. These are data from Lille at 10 years. You can see that in islet after kidney, it allows to maintain the kidney graft function up to 10 years to stable values. These are data from Milan, and these are remarkable data because they were obtained in a cohort of patients that was transplanted before the Edmonton protocol. And you can see that if you separate patients with, these are simultaneous islet and kidney or islet after kidney patients. But if you separate patients with unsuccessful kidney transplants, that means that they had a C-peptide negative at 1 year. With a successful transplant, this is the kidney graft survival. There is a very big difference in kidney graft survival. At 7 years, 80% of kidneys were working as compared to 50%. And this has also an impact. Same cohort of patients at 10 years. This is the whole cohort. This is patients with a successful islet graft, 90% survival at 10 years, unsuccessful. It's more in the range of 40%, and all these patients died of cardiovascular events. So now, last part of my talk, how do you achieve graft survival? So we have data from the CITR. Insulin independence, there is no multivariate analysis. Determinants of insulin dependence are numerous and they are different. For islet transplant alone, there are 29. And islet after kidney, there are 11. This is univariate analysis. I don't think we can do much about that. What about we tease out the common determinants, common to ITA and IAK? The ERA was a determinant that was important. It means that we have made progress after 2003, which is good, a good thing to know. The baseline insulin requirements were important. It works better if you don't have high metabolic demand. The recipient gender also is better. It's probably the same. But then at the end of the day, what really matters was the total transplanted islet mass, number of infusions, number of islets infused, number of islets per kilogram body weight. And if we look at C-peptide for islet transplant alone, it's more or less the same. Number of infusion is important. Here, the use of calcineurin inhibitor in the regimen was important. Islet culture played a role. Recipient age. For islet after kidney, again, islet number infused was important, and the era 2003 or later. But really, what seems to matter a lot is the number of islets, the islet mass that is transplanted. This is about achieving graft survival. I think this is an important thing because this shows, it was from the 7th report, and from this paper in Diabetes Care, it shows that patients who have achieved insulin independence are more likely to maintain function 4 years later. Patients who never achieved insulin independence were at 30% less chance of having some function 4 years after the transplant. And this is something that we also found at the University of Geneva. If you ever was off insulin at 10 years, this is actuarial again, 70% chance of being of having some function. If you never were off insulin, 20% chance of having function. So the group of Lille has had the very astute concept of primary graft function. It was defined as a beta score. This is the Edmonton beta score, 1 month after the last infusion. And they separated their cohort between an optimal beta score, which is 7 or 8, or a suboptimal beta score, less than 6 or less. And you see that if you have an optimal beta score, your chance of being off insulin at 5 years is almost 60%, and your chance of having a graft still functioning, C-peptide positive, is 100%. And they have confirmed that in their 10-year report, where patients with optimal graft function had almost 50% insulin dependence at 10 years and 90% of function. But of course, as they say, they deliberately optimized primary graft function by initially administering 2 or 3 sequential islet infusions in a very short period of time. So this is very important, I think. So to conclude this overview, graft survival and graft success must be defined. There are the Eagles criteria and the Eagles 2.0 criteria that have been published. Graft success is not should be evidence of function and a positive impact on hypoglycemia and HbA1c. Graft survival does not equate insulin independence, and the lack of insulin administration is not necessarily a reflection of a perfect graft function. 10-year islet graft survival can be estimated in a single center series at around 60 to 75%. And long-term graft survival is mostly determined by the transplanted islet mass and primary graft function. And with that, I would like to conclude, and I hope I was not too long. Thank you, and I think we will take questions at the end of this talk. Thank you very much for listening.
Thank you. I think we move to the next speaker, Professor Herring from the University of Minnesota, and we will face the problem of the best immunosuppressive protocol in islet transplantation.
Thank you, Paola, and the Congress for giving me the privilege of participating in this webinar. The second talk in this webinar will be on the best immunosuppressive protocol. I want to start by disclosing my relationship with Diabetes Free, and you are welcome to share details of this presentation. So I will discuss induction regimens, maintenance regimens, briefly discuss old but unanswered questions, novel anti-rejection strategies, and new challenges and questions. And I will make an effort to convince you that profound changes in our approach to preventing rejection and autoimmune destruction of transplanted islet cells are both needed and now also underway. Starting with induction immunosuppression, different strategies were investigated in these clinical trials. The landmark study by James Shapiro reported in 2020, our paper in 2005 in JAMA, and the phase 3 trial of transplantation of human islets conducted by CIT. I think the analysis done by Mike Rickles and Ali Nagy and reported in 2013 in Diabetes, comparing the Edmonton protocol and the CRT07 protocol, is very insightful and very important. And as we all remember, the induction in the Edmonton protocol was with anti-IL-2 receptor antibody, whereas in the CRT protocol, it included anti-thymocyte globulin and soluble TNF receptor, etanercept. The maintenance strategy was identical, and perhaps also in the CRT07 protocol, other important factors included high-dose heparin and insulin, and also the use of pre-transplant culture. But when comparing the beta cell secretory capacity at day 90 post-transplant, there were really significant differences, and the capacity was doubled by and probably associated with the induction strategy in the CRT07 trial compared with the Edmonton trial. And that was achieved even though the number of transplanted islets was 9,400 in the CRT07 protocol, and in the Edmonton trial it was 14,000 per kilogram. Well, Thierry has already shown data from the collaborative islet transplant registry. I asked the registry to run an updated analysis and was given a number of new slides. And here, looking at outcomes in analyzed for induction in ITA recipients that received more than one transplant and all received the same maintenance immunosuppression. The best 5-year outcomes, 75%, were achieved when looking at the endpoint, the composite endpoint, A1C less than 7% and absence of severe hypoglycemia in patients who received T-cell depletion. And that was significantly higher compared with the IL-2 receptor antibody group alone. When really asking the question, what are the rates of absence of severe hypoglycemic episodes in different patient cohorts? And the outcomes were remarkably good, and very high rates were achieved across the board, with the highest rate, namely 96% at 5 years in the group that received T-cell depletion plus TNF-alpha inhibition for induction. Looking at insulin independence, the best outcomes in the group that received T-cell depleting antibodies, and the outcomes were better compared with the IL-2 receptor antibody induction only. Now I just inserted this slide. So we reported the Minnesota single center results with respect to long-term survival in 2012 in this paper in HAT, and our results in Minnesota are in the black bars, and we compared outcomes achieved with the same regimen, including T-cell depletion and TNF-alpha inhibition, achieved by other centers using the same strategy that had reported results to the collaborative islet transplant registry. And one point that was made in this paper was that comparable 3 and 5 year insulin independence rates were now achievable after solitary pancreas in white bars and islet transplantation, black and gray bars, in non-uremic patients with type 1 diabetes. Now, analyzing more recent data and looking now at maintenance, again in islet transplant alone recipients that received multiple islet transplants, best outcomes with respect to A1C less than 7% and absence of severe hypoglycemia was achieved in recipients who were treated with mTOR inhibitors and calcineurin inhibitors post-transplant for maintenance. And with respect to insulin independence, again, significantly better outcomes were achieved in recipients who were treated with the mTOR inhibitor plus CNI regimen for maintenance. So I think we have, as a scientific community, looked at outcomes, and we have shown differences according to protocol, and the data is all interesting. But I think it is fair to say that there are a number of questions that have been around for a while, but have remained unanswered, and some of the more foundational questions. And we all face late failure, and Dr. Berney really showed it in a great review, outcomes achieved across the world with different protocols. I think there is a question that we should, as a scientific islet transplant community, try to address this, and that is whether late failure of initially successful islet transplants is due to inadequate efficacy of immunosuppression to prevent alloimmunity and rejection, or inadequate efficacy of immunosuppression to prevent type 1 diabetes recurrence, or inadequate efficacy of immunosuppression to promote engraftment, or whether at the end of the day, a late failure of initially successful islet transplants is due to immunosuppressive toxicity over time. And I think the really insightful work conducted by the Lille group and also discussed by Dr. Berney suggests that very favorable outcomes can be achieved when a very high rate of engraftment is achieved shortly after transplantation. And that can be achieved with multiple transplants as presented by the Lille group, or perhaps also by using a protocol, an immunosuppressive or immunotherapeutic protocol that promotes engraftment of islets. And again, we know very little about underlying reasons really accountable for failure of transplanted islets. I think it is also important to emphasize that novel anti-rejection strategies are now finally being investigated in clinical trials after years of really using very similar protocols across the world. And of the 23 trials in islet transplantation listed in clinicaltrials.government currently recruiting patients, I will just list 2 that are active at the University of Alberta. One is testing poly-Treg immunotherapy in islet transplantation that was first posted in 2018. And more recently, a clinical trial that is testing AT1501, which is an Fc-engineered anti-CD40 ligand antibody. And in the title, I put novel in quotation marks because that is a strategy that was first discussed and presented by Norma Kenyon and Camillo Ricordi more than 20 years ago in papers in Diabetes and PNAS. And I think it is really great to see that now, after so many years, this is finally seeing the light of the day and will be explored in islet transplant recipients. And I believe it will be of great interest to all of us who work in this field. But I think the best immunosuppression is probably no immunosuppression. And I believe innovation to zero maintenance immunosuppression will become mandatory if we really want to see much more significant utilization of beta cell replacement in people with type 1 diabetes. And there are a number of strategies that are under investigation. We have worked on strategy 3, that is in vivo expansion of antigen-specific regulatory networks, and reported recently that long-term tolerance of islet allografts can be achieved in non-human primates induced by apoptotic donor leukocytes. And you see the outcome in one of the non-human primates showing sustained normoglycemia and insulin independence even after all immunosuppression is discontinued as early as day 21 post-transplant. And this outcome was achieved with a fairly low dose of islets, only 5,500 islet equivalents per kilogram, and suggesting that when tolerance is induced before islet transplantation, the dose required might be lower, the dose required to restore insulin independence. And this outcome was achieved in all studied animals shown in the blue group, the group that received apoptotic donor leukocytes together with short-term induction. So I think under new challenges and questions, I think what is another very exciting development in our field is that clinical trials of stem cell-derived islets in type 1 diabetes are now underway, and I know Lorenzo will discuss this in detail. The point that I want to highlight is that 2 of the clinical trials that are currently active and recruiting patients are performed in recipients who receive systemic immunosuppression. And I think that will be really an interesting experience, and we'll learn from studies as they get underway and as results will become available. So I think to summarize, what is the best immunosuppressive protocol in islet transplantation? And I think the answer is it depends. And it's a good answer to many questions, but it clearly depends on transplant type and the metrics that you consider most important. I think it's fair to conclude that when induction is considered, superior results are achievable with T-cell depleting antibodies plus minus TNF-alpha inhibition. Maintenance, superior results with calcineurin inhibitors plus mTOR inhibitors. And the other point I believe that is important is that innovation to zero maintenance is going to be needed for this therapy to be embraced by patients and diabetes care providers. And I believe it is also attainable, as more and more results seem to suggest. And finally, immunosuppressive requirements for stem cell-derived islet products remain to be studied and are likely defined by the islet product, whether or not the stem cells underwent gene editing or other modifications. It's been great to be with you. I wanted to thank our patients, colleagues, collaborators, fellows and students and support staff, and NIH and JDF for funding our work. And I wanted to thank in particular Cassandra Ballou and Elizabeth Payne from the Collaborative Islet Transplant Registry for running analysis to be included in this presentation. Thank you for your attention.
Thank you, Bernard, for sharing this experience and the new projects in the field of immunosuppression in islet transplantation. And I would like to introduce Rodolfo Alejandro from the Diabetes Research Institute of Miami. And we will face the problem of immunosensitization in islet transplantation. Thank you, Rodolfo.
Okay. Sorry. Okay, so I'm on mute. Okay, so good afternoon and thank you very much for the invitation to present our data on the long-term persistence of allosensitization after islet allograft failure. These are my conflict of interest, and you can share the details of this presentation. So, anti-human leukocyte antigen HLA antibodies can develop after exposure to allogeneic tissues through blood transfusion, pregnancy, or previous transplantation. Although we know that islet allograft survival at 1 year is approximately 80%, graft function decreases progressively with time, and after graft failure, immunosuppression is often discontinued in subjects receiving islet alone, since the immunosuppression is no longer needed. The need for a relatively large number of islets to achieve adequate metabolic control has led to the use of multiple donors per recipient. Therefore, we may increase the risk for allosensitization to multiple HLAs. Based on the published studies, allosensitization develops in approximately 40 to 70% of islet transplant recipients following discontinuation of immunosuppression after graft failure. This is our data that was published in 2007. This is the initial data from early 2000. And if you look at the last panel, you can see the development of allosensitization in virtually all patients who discontinue immunosuppression to both HLA class 1 and HLA class 2 measured by flow cytometry at that time. DSA also was developed to one or more donors in the majority of these patients after discontinuation of immunosuppression. The group from Edmonton, Dr. Campbell also described similar results with recipients who discontinue immunosuppression broadly sensitized, 71%, the development of donor-specific antibodies, and some of them develop antibodies, the DSA, while on immunosuppression. And he already noticed that although some of the antibodies appear to diminish, the majority persists over time at the time of publication of that paper up to 42 months, or 3.5 years. A larger data set from the CITR also demonstrated the development of allosensitization after discontinuation of immunosuppression. Not only that, they also show the development of allosensitization in 32% of recipients despite being while on immunosuppression. This is data up to 6 years of follow-up. Other groups have also described this phenomenon of allosensitization after graft loss, and the paper from Shaw, published recently, show also that DSA was associated with bad outcomes. We are presenting here the long-term persistence of allosensitization after islet allograft failure that was published recently in Transplantation. Is available online if you want to look at it. And there we describe our data on patients transplanted between 2000 and 2017. We transplanted 56 subjects during that time for a total of 100 infusions. Of the 56 subjects that were followed, some were lost to follow-up, and some, after developing graft failure, decided not to participate. So of the patients who agreed to participate in a long-term follow-up study, 17 of them were followed for, some of them have been followed for over 15 years, and were compared with those that still have graft function in our institution. So a total of 35 subjects were included in the analysis. There are three groups: those that fail in the islet after alone group, those that fail in the islet plus CD34 enriched bone marrow group, and those with graft function. As always in islet cell transplantation, the majority of subjects are female, and the age was similar, and duration of diabetes may be longer for the bone marrow group, but none of them became statistically significant. These subjects receive islets from 1 to 3 donors, depending on the protocol. And very important to notice, those that had graft failure in the IE group or the islet transplant plus bone marrow group, islet alone plus bone marrow, were treated with the Edmonton protocol. Those that still have graft function, 50% of them received T-cell depletion strategies. They have a lot of mismatches depending on the number of donors that they receive. And also they develop donor-specific antibodies, mainly in the graft failure group. 11% of those with function developed DSA. DSA was against class 1 and class 2. Maybe the most important slide of the study is this slide that shows CPRA, calculated PRA as a function of time, and clearly show that before transplant, during graft function, there was no allosensitization, but as soon as immunosuppressions were discontinued, there was the development of allosensitization that have persisted in some subjects up to 15 years. So the persistence of these alloantibodies is the new finding in this protocol. The next slide is the same slide, except to emphasize that pre-transplant there is no alloantibodies during graft function, but as soon as you discontinue immunosuppression, that's when you start seeing allosensitization, and that's become it's statistically significant. While on immunosuppression, 22 subjects have became allosensitized, and 11% have developed donor-specific antibodies. A difference than the Shaw paper that was mentioned before, we haven't seen any correlation between the development of DSA and allograft function. Can we prevent allosensitization? We are at the present time, we are conducting a study with treating patients after graft failure with mycophenolic mofetil in order to prevent sensitization. Among 3 subjects in the IA group who experienced graft failure, they didn't develop, 3 subjects didn't develop allosensitization in our group that we studied. 2 of them were treated in our new protocol of using MMF to prevent allosensitization. And 1 patient was not allosensitized after discontinuation of immunosuppression. This patient received IVIG prior to graft failure due to parvovirus infection. Graft failure here was because we discontinued immunosuppression, but that patient received prior to discontinuation of immunosuppression IVIG, but most likely is responsible for the absence of allosensitization. In conclusion, allosensitization was minimal while subjects remain on immunosuppression. After discontinuation of immunosuppressive therapy, the majority of subjects became allosensitized, and allosensitization has persisted in the majority of subjects after discontinuation of immunosuppression. Some subjects have been followed for over 15 years. The persistence of allosensitization is of clinical importance since it may result of longer transplant waiting list times for identification of a suitable donor in case of required a subsequent transplant. That doesn't mean that will not be possible to transplant these patients, but they may have to wait longer. This phenomena of allosensitization to HLA antigens is not new. And in the literature, you can find that pediatric patients receiving implantation of cryopreserved valve or non-valve allograft without immunosuppression have also shown persistence of anti-HLA antibodies for up to 18 years. So once you develop antibodies against HLA, they seem to persist for a long period of time. The reason for this persistence, this is just all theoretical, is not known, but we can say that maybe the persistence of cells of donor origin that's responsible, that persistence of the alloantigens in long-lived dendritic cells, or the presence of long-lived plasma cells that are generated during the alloimmune response is all theoretical. And treatment with MMF for 2 years to prevent allosensitization after islet graft failure may be an effective therapeutic option, although large-scale studies are required to confirm our findings. Our study is still ongoing and we haven't analyzed the data on the subjects, but it suggests that may have an effect on preventing allosensitization. This is the group in Miami and our funding sources that is responsible for this study. And thank you very much for your attention.
I thank you very much, Rodolfo. And at this moment, the last speaker is our friend Lorenzo Piemonti from the Diabetes Research Institute of Milano San Raffaele. And he will introduce us to the new tissue sources. How long does it take to clinical trials?
Thank you, Paola. Thank you, everyone. Good evening or good morning, depending where you are. The point of my presentation is related to the possibility to use alternative source of beta cells, not just islets from organ donors, but from other sources, and how far we are from the clinical trials with this type of tissue. These are my disclosure of conflict of interest, and for sure you are welcome to share details and the presentation on social media. I want to start my presentation just remembering or just showing you that we are now in a new horizon in the field of biology and clinical application of biology. Something that today we have, something that it was not present 20 years ago. So the possibility to really treat disease by using cells, stem cells, and gene therapy. And this is the first generation represented here of what we call the ATMP, so the advanced therapy medicinal products. And these are not just a science fiction, it's reality. And this is just the first generation of this type of product. Because now there are at least 15 different ATMP approved in the EU, and more or less the same in the USA. But this is just the tip of the iceberg, because there are more or less 2,000 clinical trials ongoing in the world, mainly related to the use of stem cells and the gene therapies in phase 1 and phase 2 clinical trials that will allow in the next future the possibility to treat condition and disease by using this type of approaches. The first concept that is, the second concept that is relevant also in the field of diabetes and beta cell replacement is that this condition represents really the perfect model to test new cells replacement therapies. This is because diabetes, or at least type 1 diabetes, is mainly related to a loss of a single specific cell type. So this makes the story much more easy. In this context, we know that the cells not need to be transplanted back in their original site, so we don't need to put the cells in the pancreas. And this is something that is not common in the field of beta cell replacement. If you start, or if you think about brain damage, for example, you have to put new cells exactly in the same place in which they were originally, and they have to connect what is around. That's something that is very complicated. While in the field of beta cell replacement, this is something that we can do by using a different site. For sure, in this context, we have a well-defined clinical outcome, as also was presented before by Thierry Berney, and well-defined markers of function in vivo. And we know by the experience of the beta cells of this islet transplantation that we can really cure diabetes in this context. So the point is, islet from donors can work, they can really cure diabetes, but they will be never enough for curing all type 1 diabetic patients. So we have to think something different if you want to move from a small number of subjects to a large number of subjects to be treated. There are two different strategies that can be used to obtain functional insulin-producing cells. One is more related to the possibility to induce an endogenous regeneration, and the second one is the possibility that is related to the replacement of the cells. For the endogenous regeneration, you can imagine to do some way beta cell expansion that could be done in vivo or ex vivo by inducing proliferation of the beta cells, or you can imagine to transdifferentiate or differentiate pancreatic stem cells, or if they exist, or duct or alpha cells in the pancreas. But on the other side, replacement is mainly represented by the organ transplant or the islet transplant, as we saw before, but also by the possibility to obtain different sources of beta cells, mainly by modification of beta cells or creating beta cells in vitro by generation of endocrine cell line, or by differentiation starting from stem cells. So if the question is how long does it take to clinical trials, the answer is we are already in clinical trials by using different sources of beta cells. And these are the, as also Bernard reported before, these are what is ongoing already in clinical trials by using pluripotent stem cells-based clinical trials or porcine islet-based clinical trials. These two different sources of beta cells. We will not speak about porcine because this needs a specific presentation. We will limit it now, our presentation, about the possibility to use pluripotent stem cells as source of new beta cells. Why we can do now this in a clinical trials? Because now we have protocol that works for making progenitors, pancreatic cells or beta cells, starting from pluripotent stem cells. And here are the more relevant of the pillars in this field in terms of what was published for the possibility to really obtain endocrine tissue starting from pluripotent stem cells. And just to give you an idea of how much powerful is this type of approach, this is our experience by using IPS. On the left, you have a time lapse in differentiation of the IPS. On the right, you have pancreatic islets. And if you look after more or less 25 days, you can really have the idea how much close are the two types of the cells and how much efficient is the possibility to obtain islet starting from pluripotent stem cells. But this is just how they appear, but that does not mean that they are really able to secrete insulin to do what they need to do. So if you look at what they really are in terms of expression of insulin and the possibility to produce, they are really able to produce insulin. They are really able to release insulin, and also they are really able to secrete insulin in response to glucose. And this make this type of cells a new source that we can use in clinical trials and hopefully in the future also in the normal therapy of type 1 diabetes at least. So which is the horizon now? This is more or less what is ongoing in the field. So you can start, or you can imagine to start from subject with diabetes, and you can obtain from this subject skin biopsy or blood to have primary culture of cells. Or eventually you can obtain these cells from starting from a third-party donors and to do a reprogramming to obtain induced pluripotent stem cells. On the other side, you can eventually start from embryonic stem cells that are the more famous pluripotent stem cells available. And starting from this type of source, you can induce differentiation of these cells in human-like endocrine cells. You can induce immunoprotection, or you can in some way protect these cells by using different strategies that could be encapsulation, micro or macro encapsulation, or gene editing to block the recognition of the immune system. And then you can come back to the original subject and infuse these cells to cure diabetes. Of course, there are still some problems, some issue in this field, and these are reported in red in the slides. But where we are in clinical trials, if you have a good embryonic stem cell line, and if you have a good protocol to obtain progenitor endocrine cells, and a good system to encapsulate these cells, you can try the first clinical trials. And this was what was already done in the field. And the major point under discussion and under evaluation by the clinical trials that are ongoing by using this type of approach is related to which type of device has to be used for the transfer of the cells. And there are at least 3 different candidates under evaluation in this time. The first one that was tested is the so-called PEC-NCAP. That is a device that is characterized by the fact that it's a closed device. Closed device means that nothing can go inside, no vessel, no leukocyte. And this means that you can use this type of device without immunosuppression. And on the basis of this type of device was developed the first clinical trials in the field that started in 2014. And here is more or less what is now known by this type of experience. For sure, it's really well tolerated as a procedure. The device, the implantation that is made under the skin in the subcutaneous space. The device was able to really protect the cells inside because there was no any evidence of immune recognition. And there are some suggestions that at least in a small number of subjects, the cells inside of the device can survive for a long term. But the major problem of this approach was the fact that the device itself was able to induce a sort of aggressive foreign body reaction that limited the engraftment of the tissue. On the basis of this experience, now the system or the approach is developing a new device that should be less proactive in the recognition of the foreign body reaction. And this is something that is just started a few months ago in a new cohort of subjects, and it's something that is ongoing during this month, mainly in the USA. The other possibility in terms of the device is to use a different strategy that is what we call pack direct, in which you have an open device. This changes a lot the horizon, because this type of device can be much more efficient in terms of survival of the tissues inside, because allow vessel to go inside, to provide oxygen, to provide nutrients to the tissue. But on the other side is an open device, and this means that also the leukocyte of the host can go inside and induce a reaction. So this type of device has to be used with immunosuppression, and this is a big difference in comparison with the previous one. This type of device was tested again in clinical trials, both in USA and also in Europe, and we were able, thanks to a collaboration with people in Brussels, in Leiden, in Paris, and and with the people in San Diego, that we were able to provide the cells. We started also in Europe this type of experience 2 years ago. And what we learned from this type of trials. Now we know that if you use this type of approach, you can maintain for a long time the tissue inside of the device for more than 1 year. And we have the evidence that the tissue that is inside of the device can really produce insulin in response of glucose. Not too much in terms of quantity, but enough to demonstrate that these cells that were originally embryonic stem cells, they can survive for at least 1 year, and probably much more, and they are able to differentiate when implanted in insulin-producing cells able to respond to glucose. But this is again just the first line of a number of product and tentative that will be available in the next years. This is the more involved industry or pharma at this time in the field. The more interesting, and probably the next one that will be in reality is already tested in human, is derived from the experience of Vertex. And this type of trials is a little bit different from what was already done by the previous strategy, because there are some differences. We again start from an embryonic stem cells, even if it's different from the previous one. But instead of producing progenitor cells that need time to develop, to differentiate in beta cells when they are implanted, with this type of trials, the idea is to go with something that is already a beta cells when is infused in human. So something that is at the late stage of differentiation. And the last difference in comparison with the previous approach is that in this case, the approach will not introduce any immunoprotection in terms of device or gene editing, but it will use immunosuppression. So what is more traditional in the field that we call, we know very well from the experience of the beta cells transplant, islet transplantation. And last but not least, also the site of the infusion of these cells will be the liver, so the same approach, intraportal infusion, as for the islet transplant. If this will work, probably there will be a second generation and the third generation of trials using this type of cells that will be implemented by the use of device without immunosuppression, and probably the third generation by using gene-edited cells able to escape from the immune recognition. Thank you for your attention, and obviously we are here for any answer from the public.
Okay, thank you, Lorenzo. I don't know if we have time for discussion and answers. I don't know.
Gabriel?
I have only a very short comment. That is it was very interesting, and I think that we have learned that there is a great future for the islet transplantation, because we have learned about what we have to do if we have the allosensitization, for example, and that we have many new ways to achieve the new protocols for moderate or reduce the rejection, and to improve the survival of islets. And the last part, what we can do with the new sources that are close to us in the research. Not there is not a so long way to achieve. I don't know if we have. Yes, we can extend the webinar by 10 minutes, but the 10 minutes are now. I don't know if there are some answers from the speakers or more comments.
Well, maybe I can start by asking a question, Paola. So I enjoyed all the presentations a lot, and of course, it is very apparent that this will be an exciting time in an exciting field going forward, with a lot of innovative new strategies being tested. So I wanted to ask one question. Lorenzo, you showed really the progress in the field of stem cell derived islet beta cells. So I think when new trials now get underway, or additional trials, so what can we learn with respect to the potency of islet products that are investigated in comparison to human islets prepared from organ donors? And I just like to ask that question to see what are the expectations, and it's just one of, I understand, one of many questions related to the clinical trials that are currently underway and are recruiting and probably very soon transplanting patients. Please, Lorenzo.
Yeah, this is really a key question in the field. You know, we know that we did a lot in the preclinical models to try to understand how much of these cells has to be used, how efficient they are in terms of insulin secretion, and then. But there is at this time, a clear idea if the potency or the efficacy of these cells are really comparable with the human islets. And this is something that we start to learn now. With some, as usual, confounding elements in the model, also in clinical trials. The measure is related to the problem of the engraftment again, because engraftment still remain a problem. independently by the type of the cells that you use. And for the first experience by using device, one of the major problems is the engraftment again, because the device is something that interferes with the engraftment because induce problem, induce reaction, and in some way also limited the possibility of connection of the tissue with the host. The second generation of the trials that will now is starting and by the using the Vertex product will be more interesting by this point of view, because there will be no device, so same site, same immunosuppression. And also cells that are already well differentiated in insulin producing cells. So this will teach a little bit more about the potency of the approach in terms of efficacy.
Yeah.
So we will see.
Is your expectation that the cell therapy product is pretty much developed, and that the future clinical research in the coming years will focus on points that you just mentioned, will focus on implantation technologies, will focus on anti-rejection strategies, or will we rather see next generation of islet and beta cell products? Where will innovation be needed most?
I think that is the second part. So the engraftment, how to make these cells working in human, not in the differentiation. I think that we have a lot of good protocol, a lot of good product in terms of cells that can be used. And now is the time, or is our time. And our time, I mean, the people that worked in the past in the field of islets, and to put the experience that we developed in the beta cells implantation in human, and to shift the experience in this new product, and to make this really a potential cure for diabetes. But I'm sure that the problem is still immunosuppression and engraftment. These are still on the table and not yet solved by the stem cells approaches.
And maybe a last final point, and then I will stop. Will we be seeing many more studies on embryonic versus iPS-derived islet beta cells, or will there be a whole line of investigation required to study iPS-derived products?
This is also another key question, which is the best one in this, between these two. I think that each cell, pluripotent stem cells, can be differentiated in insulin producing cells. And this could be more or less the same if you start from embryonic or from iPS. The problem is that there is no one protocol that is good for all the cell line that we have. So each cell line needs to be optimized. So the backbone of the differentiation is more or less the same, but the single cell line has to be optimized to obtain the best. And this is make the story a little bit more problematic if we imagine to do an autologous patients derived cells as a starting point, single patient, single cell line, because this could be not easy to be done if you imagine to extend to a number of subjects that is more than 3, 4, 5 subjects as in a phase 1 clinical trial. In terms of efficacy, it's the same, and I suppose that is also the same in terms of immune recognition and all the other aspects of the field.
Thank you. I think there is no more time. I think we would need a lot more time. There is only 1 minute for an answer to a question I see. Should we be trying to more closely HLA match for islet transplantation from John Casey? I think Rodolfo could answer.
We have been looking at our data, also the CITR, but our data, we have seen that if you match, you have better outcomes, but you have to avoid DR34. So if you avoid DR34 and match for others, you have better outcomes. DR34 matching is bad.
Okay. In the while, I thank all the speakers, the participants, and I remind that the recording will be soon available on the ESAT platform, YouTube, Transplant Live and Congress platform. And I hope to see all of you for the ESAT Congress at the end of August.
Thank you.
Thank you.
Okay.
Bye-bye to everybody.
And bye to everybody.
Bye-bye.
Thank you very, very
Thank you.
much.
Bye.
Okay.